big picture, the procedure itself is super easy. So that's something I've trained so many residents on, and it makes it exciting it makes me excited for the course because teaching that part is so easy. So all the other stuff, I don't know how they're going to be able to directly apply it, but here's what I'm thinking. A lot of tongues and tongue ties go undiagnosed through all the way up to adulthood. I'm one example. I had it, I knew I had it, but I didn't know what to call it. And on that note, I recognized it in dental school. I wasn't a hypochondriac, but I did recognize it and had it evaluated. Oral surgeon released it. And it was honestly night and day difference between prior to and after. Now, I was an adult. I didn't have any myo or anything like that. And I would say I had a little regression. And then I only had one stage. It wasn't done by a laser. It was done by the tent. One of the ways that I don't teach, but it's a tent. It's a tried and true way, but it's pretty bloody. I like to do it as bloodless as we can via the straight mosquito method, but or the laser. But on that, applying it to their practice, a lot of this goes undiagnosed. So I'm working part-time in a general dental practice, and I'm catching 3 or 4 a week, just in one day a week. And that's just because, and then the patient's like, well, no one ever told me about this. And then it goes back to Airway and all those other things. And a lot of them are on CPAP, and have basically compensated for it their whole life. And then no one's ever caught it because all we're looking at is the lateral border of the tongue. That's all we care about as general dentists. Lateral, anything with that, because you want to refer, you want to catch. I get it. And I've seen the other end of that, where, head and neck cancer is a serious thing and whatnot. But the catching the tongue tie is going to be much more common. And then you'll be able to get the pipeline going with your myofunctional therapist. You can go.
All I wanted to add is like some of the referrals we're getting from general dentists or dentists are the hygienists are catching it. Then the dentist is like, oh yeah, that's a tongue tie. Let's figure that out. And then patients are usually in like more of a, oh yeah, I have this symptom. I didn't think it was associated with anything. So that's what we're seeing in adults. Is it's like more of this backwards look. And the research is kind of like testing it in all these like misconstrued ways. But like I think we're seeing a lot of symptoms align with it in adults, more of like sleeping, like kind of swallowing issues that they've had their whole life. Maybe they had speech issues when they were younger. Nobody really related it. And so what we're kind of seeing in hindsight is that reaction of like, oh yeah, I have all of those. And what we're seeing in practice is the best approach is kind of hygiene's working, they're doing that, and then they're bringing it to the dentist's attention, and then they're referring it out, where maybe they could be keeping it in their practice, getting it done, do a frenectomy day, depending on their like patient population and their how many they've got in clinic, and then deciding, oh, is this something I introduce once a week? Is this something I introduce monthly? And what does that look like? Do I need to invest in a laser? Can I just do this straight nose mosquito and kind of get it done with a scalpel?
Yeah. And what this will also do is help, like a lot of the hygienists are becoming myofunctional therapists because they see other avenues, and this is only going to help support their itch for that, and then also keep a lot of, I guess, gain their trust in that manner, because otherwise they go get the training and they're like, my dentist isn't even managing this, they're not even catching it. So in that definitely one of those things that we want to get all dentists up to speed on, because they're gonna be able to be the primary on this in this particular situation. I can tell you most PCPs are not checking this. They're going to go straight to CPAP. They look right past the tongue and teeth, and they look towards, are your tonsil, what's your Brodsky, what's your melon patty, and all that type of stuff. They're not, and then airway in terms of nose to lungs, not tongue and teeth, and evaluating tongue and lip tie. So
Yeah, I totally agree. And then from my own personal experience, I had my tongue tie release when I was in junior high, and I didn't do any myo, and now I have to do it again. So two of my kids got theirs done on Thursday, and I was going to go do it with them out of solidarity, but my youngest still needs this done. So I was like, you know what, I'll hang with him, so he doesn't have to be alone on the journey. It was really interesting because if I was to do it, and I do a lot of surgery, if I was to have done my kids, I wouldn't have gone as deep, and I wouldn't have released the genioglossus as much as the practitioner did. And it was cool. My son has like chronic neck pain in this region, and not all the time, but it's like it's frequent enough where I'd say it's chronic. And after we did the release, he turned his head and he didn't have any pain in there. So it's really amazing how the musculature and how it's all attached affects everything, even affects like forward head posture and all the
Uh-huh.
things. And then we
Yeah.
look at it like full arch patients. I've noticed a huge link between airway and terminal dentition. You
Uh,
meet these patients in their 50s and their 60s. They brux all night long because of airway issues, and either the teeth are ground down to the nub and they're miserable to extract, or
yeah.
the bone gives and they're all periodontally involved, and the tongue is huge, and then you're trying to do surgery around this large tongue. So I think there's an
Uh-huh.
application to get these patients on myo first, then do the tongue tie release while you do the surgery. You can incorporate your medical billing if that's something in your practice. You got the super billing aspect that I know you're going to touch base on at the courses.
Yep.
And so there's so many different things that you can do for adults. There's so many like adjuncts for kids. I'm a huge advocate. I mean, obviously we all have young children. So I'm a huge advocate for taking care of them now so they don't have to deal with the stuff as adults. Um,
Yes.
and then also my son, when we did his expansion, unfortunately, my eldest is my guinea pig for a lot of my training. And so we expanded him without Mayo, put him in a TPA, held him. He had, relapse occur. And it's just because his tongue couldn't get to the roof of his mouth to hold it. So now we're going to have to re-expand him, which he wasn't a fan of. But now we did the tongue tie and the Mayo first. And now we're going to re-expand him and get him to where he needs to be. So I think understanding from people who do this all the time, the proper sequence and order and how to do it is critical. And
That's
I always thought like I knew how to do everything at least pretty well. But again, testing it out on my own kids, I've done things out of order, and going out of order could take you an extra year or two. So understanding the steps and the sequences is huge as well.
absolutely akin to cleft surgery. Like I did nasoalveolar molding, right? You don't start with the surgery first and then do NAM, nasoalveolar molding. You start NAM first. 1 week, you're taking a VPS impression. I hope nowadays they're scanning the patients, printing the molding plate, right? Adding the button, doing the taping. It's all sequenced all the way up to 3 to 5 months prior to the first surgery, where they basically graft the bone site and at the alveolus, whether it's unar or bilateral, and then connect that first, right? They don't do the palate right off the bat. They wait, but it's all a sequence, and it's very similar to, the lip or tongue tie, and that's where we're catching a ton of infants, and the first signs, I mean, are difficulty breastfeeding, whether it's mom or infant or the dyad, both, and so that's where we're catching these kiddos, and we're preventing all this initially as well, and then taking it to the kiddos, those are probably the most challenging, just from a behavior standpoint.
They don't have to be. I
But they
think
don't have to be.
no, and I was gonna say too, we've worked with another dentist who Michael's trying to get to come do wisdom teeth too, by the way,
Mhm.
locally. And we talked a lot about kids, and this may not be as applicable to the attendees, right? You're working with a lot of implants that we're tying this course in for right now, but like getting kids before they're 12, expansion, myo, and the release if they haven't had it done as an infant, so that you're preventing the need for ortho down the line, or like getting in there orally ahead of time. I don't know the science or I have the dental background like you guys do and understanding that aspect of things, but from just that growth perspective, trying to get in there and establish that is something we're looking into as well. So like we're like hardcore expanding right now and networking and mapping in within what we're doing. We next door have Cairo, and body work is like really essential. You talked about your son's neck. I'm really
Mhm.
like looking at that from not just like kiddos, but adults, they've lived, as we just discussed, for however they have, and working with some sort of OT, PT, chiropractor, even like just basic body massage. Same thing with like OMT, where they're getting in there pre and post operatively. Just having that release done frees up so much in regards to front and posterior chain, and like how that affects everything posturally. So we're working closely in like how we can tie these things in, what's going to be beneficial for the patient. Obviously, compliance is a big thing. Once you start doing all of these additional things they need to do, that's our biggest thing we're seeing with Myo is like on the front end, a lot of the patients are really eager. They do the front end with OMT, then they get the procedure done, and then they kind of fizzle. And so like they're sore, life happens, and our follow-up isn't as like in place as maybe lactation, where you're got desperate moms who are trying to get a baby to gain weight or they're in pain. And so they're going to keep that follow through because they do not want to go back through that again. So that's something that just kind of we're seeing and playing out. But even those kiddos, trying to introduce frenectomy, myo, maybe a myo brace, different things along those lines, and get everything taken care of expansion before they hit the 12-year marker, and kind of doing some preventative work on the front end that's maybe not as much in the orthodontic realm as need be.
Yeah, I totally agree. And so I just did a video on recession. So people keep asking, like, how do I make my practice recession proof? I was like, okay, nothing is recession proof, but you can be recession resistant. And so how do we do that? And you guys, touch base on these referral programs you can do. So you can get in with your pediatricians, you can get in with the lactation consultants, the chiropractors, the naturopaths, like anyone in this space, the airway doctors, all the stuff, right? The ENTs. Like now you have all these offices that have maybe 2,000 to 3,000 patients per office that all are thinking about you for this one procedure. And then if we think about the practices like an ecosystem, right? Well, how does this apply to wisdom teeth, right? So you get the kids in and you do their tongue tie release and their myo, then you do their expansion. And then guess what? You don't have a 5-year orthodontic case where they're, class 2, div 2, 5, 6, 8 millimeters. They're maybe off a millimeter or two. And guess what? Then you got a liner therapy. All of this is kind of taken in-house. It's much easier orthodontics for the general practitioner to do. You don't need to know like all the mechanics and have to worry about compliance with rubber bands or headgears or MARPs and SARPs and MSCs and all that craziness that adults have to go through. And then what I will tell you is if you take care of someone's kid and you help that kid breathe better, behave better, develop better. I'm in this stage where I have the 8 and 6 and 4-year-old, and we're making a lot of friends through their schools and kind of interacting with other parents. And I guarantee you those conversations are about that. My daughter's best friend's mother was in the dental chair calling my wife, asking questions while they're at the dentist. And they just bonded over that stuff. And now they're like a really good friend. And so parents talk about their kids more than they talk about their own problems. So then how do you get reputational awareness for your practice? You take care of other people's kids. And then the biggest burnout that I see that pediatric dentists have is they're trying to stick a needle into a kid's mouth, and then they can maybe get through that part. But then the drilling and the filling and the stainless steels and all that stuff is where like that emotional compassion fatigue kicks in. Well, what if I could tell you, hey, we can take care of kids in the way that we want to, and then maybe do a 15-minute procedure, get the sutures in before you like lose the kiddo, and then it's like, hey, we're good. Then this is like a beautiful procedure for GPs who don't have that compassion fatigue reservoir to give for pediatric dentistry, but we can still treat kids and help them. And then by doing all of that, then you get to do their ortho, then you get to do their wisdom teeth, then you get the parents, then you get their parents' friends, then you get the grandparents. So it's like this beautiful inter-referral system that all grows through lingual frenectomy. So is it just about lingual frenectomies? Yes. But is it so much more? Yeah, absolutely too.
Yeah.
Yeah.
Agreed. Yeah. 100%.
Absolutely. And on that, a lot of ENTs don't like at my institution, where I used to be at full time, OHSU, the pediatric ENTs aren't doing it. They're saying, no, we don't do tongue and lip tie. Like we don't necessarily, I don't know if they just don't believe in it or what. And then there's local ENTs here that don't want those surgeries because they're not high value enough to do in the OR. And so that's a a hidden gem of referrals is those patients that will get kind of decline from the ENT, right? Because they just don't want to do them. And so we've sourced that market, and it's definitely one of those things that's often goes unnoticed. Unless and then a lot of them do it incomplete. I would say not all of them, but a lot of them do it incomplete. Our 10-year-old, same thing, incomplete tongue tie, hospital setting, and he actually worsened after that. And so that was 10 years ago, right? I mean, and I've worked in the hospital most of my career, and been involved with many good ENT surgeons, pediatric craniofacial plastics, and they all know how to do a lot of that stuff. But then they ask, how does this affect the teeth? And you're just like, really? Like, you went through all this schooling, you can do all this, but a lot of them either do it incomplete or ask us, and then we can help them out, and show them the way, honestly. So
Yeah.
Yeah.
My brother's medical anesthesia, and he only he was in school twice as long as I was, and he had maybe 2 weeks on teeth. Like, he was like, I kind of know the numbers, and I know not to knock them out when I intubate someone, but that's
Yes.
really it. So,
Yep.
and then if we talk about order and processes, ENTs, and again, all ENTs are not created equally. My
Right.
experience with ours was not a good one, but they saw my son, my eldest, they're like, oh yeah, he needs adenoids and tonsils out. Oh, and by the way, you have a daughter, she's probably ready too. They didn't even do a clinical. They're like, oh yeah, we'll just schedule her also. It's going to run in the family. So again, it's like, obviously that's not going to be everyone's experience. But if I was to choose between lingual frenectomy and myo, and like a Vivos or myo brace, or some kind of like tooth pillow for the kids to guide the tongue in the right place, but also skeletal development, versus taking adenoids and tonsils out and maybe not even needing that out all day long. So I would do that first. And then maybe, God forbid, they still need out the adenoids and tonsils, then yeah, you got to do it. But at least you chose the path of least resistance, and you took it easy on your kids. So it's like, we're the first line on this one. And it doesn't mean they won't need adenoids and tonsils out later, but there's a really big chance. Like, all my 2 kids now who are scheduled, and we canceled the appointment, they were scheduled for adenoids and tonsils coming out, they don't need it anymore. Lo and behold, right? They don't need it, right?
Yeah.
That gives me chills, man, because that's like general anesthesia. There are risks. I've done over 2,000 OR cases under general anesthesia, right? I love the operating room in a lot of respects, but if we can avoid it at all costs, especially kiddos, I've operated on 0 all the way up to 100, and we can avoid those medicines IV, ahead of time, and maybe delay during growth and development. That's a really good thing, and they're finding more and more research on that. If it's needed, then yes. But the tongue and lip tie, definitely we keep them out of the OR. We do it under either topical for the infants or local anesthetic in the clinic. So that's one of those things that this stays out of needing any sort of sedation. I mean, we can do oral sedation if it's necessary.
We've done oral for some patients, and I will say this too: if you've got a really good myofunctional therapist and you're working ages 3 and up, those kids are amazing to work with. They have it down. They've got their tongue lifted. You get them numbed just right. And like, you're in and out, and those kids sit so well. You don't need to be some amazingly trained. You're going to have, like, of course, your kid, you're going to have some who just aren't, but like, they sit still. It's so quick in and out. Like, and that's so much better than like trying to finagle some child who's not done the work ahead of time, and now you're holding and you're trying to get their tongue. Like, we can do it.
Yep.
But it's a much less trauma. Like, it just is a better experience once they've put some of that work in ahead of time, and they're working their way, and it's like a goal for them, right? Like, you've given them this like step-by-step goal to get to. And like, with all of you as dentists for years being in this space, in this mouth, and everybody's kind of poo-pooing it. Now it's controversial. Like, we don't even need to get in that right now, but like, if this is just some easy, equitable procedure, you've got those steps in place, right? Like you just said, whether it's kids or adults, this is something so well integrated into practice. And it is like, it's just, you don't need to buy the laser. Like, you can do it this other way. The laser is amazing, by the way. I mean, hands down.
Best
but like,
results,
if it's not attainable, you can still do a really lovely procedure with no bleeding, and it goes through just fine, just the same. And it just is definitely something that I think we're missing the bar on, like you said, reaching out to all these patients who are going with, nobody wants a CPAP machine, like nobody wants to do that. And if this is just an easy step and you're working, like we're going to start like integrating sleep medicine and docs like that and going to Portland. But if you can integrate that within the practice, and like you said, you're networked, familial network, we've got that all the time, like right now too, like word of mouth spreads, like fire, like it's amazing. So I think it's something super attainable for dentists to bring in as just an additional service, right? That honestly, if they're billing medical, which is not that hard to do, and you can go even super bills out of pocket. I mean, it's really like it's not hard math to really be like, this is a beneficial thing, to be adding however many times a month, ideally, or at least once a month, have a big production day,
And then tell them about the patient that you talked to from Portland.
By us, nobody wants to see children or adults. We've got one national guru who like is
Dr.
well
Taher,
known
yeah.
in the space. He's only seen infants. There's nobody practiced who is taking adults. Like I had an adult, she said, I kid you not, 17 places in the Portland and Vancouver. I mean, we're not big, but like we're big out there. She's like, only 2 would see adults, and neither of them took her insurance, which was her factor, but they didn't see them frequently. So now you've got this procedure that by us, which you would think more people would be doing, but like it's just not something that people are doing. And yeah.
We're going to change that. Let's hop into the clinical real quick, and I just want to touch base on one thing you said as well. The kids moving around. You two are in a position where you get referrals, so you just treat the kid. As a general practitioner, if I get that super wiggly kid who I don't think can like do the things I ask him to do, well, guess what? I can refer that kiddo.
Yeah.
So I can pick and choose the behaviors of the kids in my GP practice and save myself all the stress. So I'll tell you about my kid's experience that happened on Thursday, and then you guys tell me like, okay, that's how we do it, or there's other ways to do it, and all of the above. So we actually, when we scheduled, they said, hey, do you have a sign off from a myo? And then they would see us and do the procedure on the same day as the consultation. But if we didn't, then they'd do the consultation first, send out the appropriate referrals to myo, and then bring us back in for the procedure after myo had kind of been completed. Do you guys do something similar on that end?
We try not to turn anybody away, but we're really switching towards that path of like working with myo or lactation specifically, because we're seeing how, I mean, that's my background's exercise kinesiology. So like I see the power behind that in regards to training, right? And I've seen it with patients. So like,
and experienced it.
And so we've done a lot without it. And we're kind of redirecting that path, but we do consult and procedure same day. And we try not to turn people away and make it equitable. So if somebody's like, I can't afford to do that or whatever, we do have exercises and stretching, but if you have patients put that frontal work in, like we've already been referring out, move like adults and kiddos, like moving forward, where I do a screening over the phone, and then I'm pushing them that way. And then we're kind of moving forward, because here's the other thing. So this is like something to consider too. Some of the myo can be done, and then therefore patient doesn't need procedure depending on the severity of their tongue tie. So we're also risking turning potential patients away, but I'd much rather, again, have them be in a place where we're maybe not having procedure done at all. Most of the time they're coming back, I'll be honest, but like there's, a couple where they're going to be able to do. Our daughter's a prime example. She's 15, should have had this done. She doesn't need to have it done. She's just going to do myo, and like,
that's what we want. Do we want the surgical procedure if it's necessary? Absolutely. But if it's not, and we can prevent it from actually needing to take place, I don't care I wish that for every patient, but that's just not the case. There's so many that need it. And so it's like, all right, well.
So we're seeing a two-way pattern. We're getting referrals from myo. and tons of other providers. But if they're not working with Myo, we're actually putting that referral back out there and saying, hey, this is going to be beneficial front and back end. And like, this is what it looks like. And then we'll get you scheduled when the myotherapist says you're ready for the procedure. So they give us that green light.
Now, this is where we don't want to turn anyone away. Well, if they're like, I'm not going to go through myo. It's a severe tongue tie where there's a patient that we saw at CSI. We extracted his wisdom teeth, and he would absolutely 1,000% benefit from a tongue tie release. Basic, right? And no myo. I mean, I know tried and true way that he will absolutely benefit. And I don't know the percent of what he'll benefit, but it'd definitely be 50 to 75% more than what he would if he didn't have anything. And then with myo, they can just, pre and post operatively really prime the pump and get him to be, 100%. But that's where we'll still do the procedure if the patient can't afford myo or for whatever reason they just aren't going to pursue it. So
yeah, and if you have a general practice and you're worried about retention for your hygienist and you get them trained on myo, and now you give them a little extra revenue because they can run the myo program for you, then that whole part could be, all kind of self-sustained. And then again, it helps with your retention of hygienists, which I know everyone kind of struggles with these days. And then two, I know when I do airway, like a mandibular advancement device or any type of airway treatment for a severe apneic patient, and they decide not to go for the CPAP, they sign a CPAP intolerant form. Is there any form that we could have the patient sign that says, hey, I understand the benefits of myo. Right now, I'm signing basically I'm not doing a myo form. I'm going to do the home exercises form. So then they take on the responsibility themselves. So I feel like, and again, I'd have everyone who's listening to this look into your own state legal system, all the things associated with all that. But I just want you to know that there's places and things that you can do to add a benefit to the patient, even if they're not, or they're unwilling from a cost, perspective to do everything. You can still significantly change their lives. So
absolutely.
We do the consultation, we hop in, regular consultation room. He has like a little barbershop chair. They like just threw this little clinic together, but they still were amazing providers, and the team was really amazing. You could see that they truly cared. Excuse me. So we go into the consultation room, and it's just really geared for kids. They have like all these like kid related things, and then they do the consultation, ask us a bunch of questions. He takes really good notes. He's interactive with the kids, making them feel comfortable. And then literally they just take us to a room. They have like that compounded topical that they put on. They start on the lower, then they go to the upper, then they go to the tongue. They have an iPad mounted to the ceiling, put on their favorite show, and the kids just sit back. And they also have a popsicle. So anytime that they put something in the kid's mouth that didn't taste good, they put a little bite of popsicle in their mouth also. So after the topical kind of like soaked in for a minute or two, they're like, okay, here's a little popsicle. Or they gave them anesthetic, they're like, okay, here's a little bit of popsicle. And the kids were like eating that up. And then after they let the topical set in, they went in, they did some local in the areas. My kids didn't even flinch. My daughter's pretty sensory. My son is very analytic. So I feel like if one of them were to flinch, it would be my daughter. And she didn't flinch at all. She was just super chill. They had like a little squishamello thing she could hold. They had a special little, cushion for the neck that kind of just helped them sit in the chair a little bit better. All these things were very low overhead items that are just one-time purchases type of deal. And then as soon as they went anesthetic, they just picked up the laser and they went here, then here, then to the tongue. And all the anesthetic had kicked in. There was minimal time for the kids in the chair. And then he went in and he put 4 sutures in on the bottom. So I know everyone has their own technique on that, so we'll dive into that. But walk me through that part of it. You seat the child in the chair, and then kind of how you handle that with non-laser, then diode laser, and then CO2 laser, or whatever other options are available.
So I'd say let's start with the non-laser, right? So what we would do is a lot of the same things. I didn't use a popsicle, but we do use enrichment, we call it. So it's enrichment for the kids, distraction, whatever music, whatever their favorite program is. and then get them comfortable. We use the best topical ever. It's called prilocaine, tetracaine, lidocaine, and phenylephrine, I think, at different percents. And so from there, that really worked well, right? But it's only penetrating what, 2 to 3, maybe 4 millimeters, right? So then we're using a technique that basically you give them a little drop of local anesthetic and then let it soak in, right? And you're waiting at least 30 seconds at each site. And then that penetrates. And then you give them a little bit more, not much. And then it keeps penetrating until you're able to basically place the needle to the depth that we need. And then from there, you're numb, or I should say the kiddo's numb, right? And then
using the short needles. So you have the 30 gauge, but you have the little mini shorties. Yeah.
Yep.
Okay, cool.
Yeah. And it depends on how old they are. Like the 2-year-old, we use the little short needle, and she had a severe lip tie. And then it depends on how they tolerate that, but most tolerate it really well as long as you're taking the preemptive steps to enrich them. And so, you know, let's see, the adult don't have to do that, but
Yeah, I mean, it's usually just
what
coming
else?
down to like getting them chair side, being comfortable with the space. The downside about our clinic is like it's a new place, right? I've been in a clinic and observed where the kids are familiar with it. They know the dentist. And I would say that's a really nice situation for them to be in because they're already familiar with that place. And they've had a good rapport with that dentist. And so, but like here too, like they're bringing in their own, you know, soothing kind of stuffy or thing that's making them feel better, providing blanket, pillow, comfort, and making it as quick in and out as possible. We are a small little clinic, so I usually do consult and prep stuff outside of the room so that you know we're limiting our time in this space. If we had 2 consults, we'd probably do vice versa. But yeah, so we're getting them in and we're kind of distracting, enriching, you know, providing like, you know, obviously like goodies afterwards, little things.
Yeah.
But
Or what you make that reward chest, like if you have a big chest, you make that one of those, like, well, I mean, this is one of those things that you'll get once we get done, right? I mean, every pediatric dentist probably has that. But going back to kind of the procedure, so once they're good and numb, with the 2 straight mosquitoes and a 15 blade with suturing, you're basically having them pucker and basically suction cup.
They're suctioning, which that's where myo comes into place. So like if they haven't done myo, it's a little bit of a different way to try to explain that to the kid who hasn't done it before, or trying to kind of get that taken care of. Whereas if you've got the kiddos who've done the myo, they've already really well practiced that and they can just sit there the entire appointment suctioning and you don't even have to think about it. So
and then once you have the 2 straight mosquitoes placed, and we'll teach you that in the course, at the proper level, then you're just taking a 15 and an Adsons, and you're basically excising that tissue, and then you're placing the stitch. Now I like to run it because in that case, you'll have bleeding if you don't. But you basically you start the uninterrupted at the tip of the tongue, and then you run it in a continuous fashion. By once you have the interrupted place, you remove gently the straight mosquito, and then it leaves the crushed capillary beds in I call it Mohawk fashion, but basically it leaves it crushed so that you can gently suture that without, because it's real easy just to pull it apart and then it starts bleeding. And you run that, and then you take the other straight mosquito off and run that along the sublingual ducts, or just above, I should say. And then that's that. Now, with the laser, which we have, it's so much easier to basically get in there and do the same procedure.
The CO2 laser.
So CO2 laser. And that's been a game changer. In the operating room, I've done so many cases the other way, because laser privileges in the OR in a hospital setting is like so much red tape, so much training preemptively, and then maintaining of privileges. And so I hadn't used the laser outside of rotating with ENT, and then when ENT would have a YAG laser that they would use for a lot of other stuff. So done it the other way, tried and true, so many thousands of times. The laser, once we got that in our clinic outside of the hospital setting, it's such a game changer in terms of just gentleness to tissue, no, pretty much minimal to no bleeding, and then placing the stitch is something that we're, do you need a stitch? I don't know. I always used a stitch in the last 9 years or so, and I'm 20.
We're using it on some of them, especially older kids. It's really depending on the depth that the that we're having, that the doctors need to go through. And so, and again, it's a space, but we're gonna instruct on stitching and kind of assessing that and getting that and applying the stitch. Typically, one of the issues we have is and kiddos too, is they can feel that. And depending on the kid, myo or not, it just is a sensory thing that's within the mouth, and it's in this muscle that you use every day. Sometimes it's pulling at the tissue. We have a lot of adults who actually the stitches pull out. So, but we're still placing them. And it's, we're also educating post-operatively, just like you would with any of your extractions or things along those lines, on eating and drinking and things like that. But back to that chair side, the kiddos specifically sit pretty well, and that it's that quick in and out. Your teenagers and adults are going to ask about that sensation, and it's kind of just, if you're numbed well enough, it's not going to be much. We have infants, so Michael's done it without any numbing. On
myself.
I relate it to not
Okay,
like on himself.
I wanted to try.
Sorry,
So just a little tangent. So I wanted to know what the laser felt like, right? And so I used it to touch up one area that had some scar tissue, and so I was like, no numbing. I just want to know what it feels like baseline. So I had the surgeon do that. And then I had a little area on my tongue, and I did a little topical. And then I had another area where they use some local. And so I had just like we try pretty much everything that goes in a patient's mouth. I try it, I taste it. I don't want to know what it tastes like, so I can, give them like, hey, I've tasted this. I know it's not that great, or this tastes great, or so on and so forth. So I know what it's like. And honestly, baseline, it's not bad. So it's just a little, zapping.
Michael has used the diode laser a couple of times, and we know a lot of dentists have that in office.
Yep.
It's not something we're going to say no to, especially if you already have it. It's just it's a little bit of a rougher experience, and it's not as with the tongue tissue specifically.
So
why not use cautery? Why not use a Bovie, or some other
trauma? You can use a Bovie over a diode in terms of preference.
If I had to choose, which I don't, I would choose a Bovie because the diode takes so long. I remember having the infant on the table, and I went to the scissors, because I've used the scissors as well. And over the diode. And then I've used a Bovie my whole career in other aspects. And so I would much rather choose like a battery operated Bovie that you can get pretty cheap.
$50. Yeah. $100.
I mean, like it works, right? But this one's battery operated, and it works, but it's just like, I'd rather just do it the old tried and true method, because it's less traumatic, and you're still going to have to suture anyway. So, because you're basically just burning the tissue. The laser, the CO2 laser, vaporizes the tissue. So much more gentle, so much more better suited for post-op. And so that's what we found.
Post-operatively, the patients with the CO2 laser are the ones who are having they're still sore and stuff, but their recovery times are better. And I believe there is some research between some of the different methods that are stating lasers in general are going to be a little bit less of pain when they're having recovery time. So that's what we're seeing. So chair side.
A lot less post-op phone
Yeah.
calls. Not that you can't do it with the diode, you can't do it with the Bovie, you can't do it, with the suture method. It's just, what you got in your office and what's going to work. And
if the dentists are using it frequently and it's something they feel comfortable with, I mean, I'm not saying no guinea pigs with it, it's just kind of our experience with using the diode. But again, path of least resistance. So if it's there, you've got it. You'd rather do that over the scalpel method. I mean,
yeah, and that's where we want to teach.
Process is going to be the same.
We want to teach those methods that, like, I'm not going to use a diode laser, but it'll be, similar to a Bovie. I'm not going to teach a Bovie, but basically the 2 straight mosquitoes suturing, and then also the CO2 laser. And then the scissors, probably not either, just because I'd rather just do the 2 straight mosquitoes.
It's as you can see better, and there's just a lot less blood, and it's a much, we're not able to do that on infants, so that's why you typically see scissors or laser on infants, just because it's not as achievable and the tissue is not as robust as in children or adults. But that's kind of what we see chair side.
And then you do enough procedures and you have the revenue to invest in the CO2, and then you have that thing forever. And granted, it has upkeep and maintenance and tips and all the things that go to it. But let's hop into, and then we'll kind of wrap it up because I know we're coming up on time here. But preoperatively, what I wish they would have done, this is like, I had a few qualms, but it's just like subtleties, is preoperative Motrin and Tylenol to, liquid form for the kids because they can't swallow the pills. They had pills, and my daughter, water dribbled everywhere, and she's never taken a pill before. So it's like having that preoperatively. And then post-operatively, this was my mistake, is I gave her Tylenol with those sutures in a little cup, and she drank it and it burned. So have the syringe and syringe it past the tongue, so then you don't, have pain and things afterwards. So it's really having a really robust post-operative instructions to give to the patients on expectations and all the things. And their sutures fell out at like 48 hours, and it looks like it's granulating in really well. They were only on medication for the first 2.5 days, and then after that it was mainly just before nighttime. So they recovered really quickly. It was 1 or 2 days of everyone kind of getting sore here and there, but if we stayed on our 3-hour increments of Tylenol and Motrin, everything was fine. Everyone was happy, chilling, watching a little TV, just whatever, just kind of taking it easy. So either way, I think all of that is a really nice way to incorporate it into the private practice. But just if you guys could really quick cover how you handle post care, and then we'll kind of wrap it up, and we'll get this out to anyone who's interested in implementation in their practices.
Well, the patients on their own with post care, we don't cover that at all. No, just kidding. Go.
That's my wheelhouse. So we're definitely recommending acetaminophen and Motrin. I would say we leave it where we live. People don't like to use that stuff as frequently. We suggest Genexa brand is more of an organic, natural brand, but we've got people using a lot of homeopathic methods. So I kind of am a little bit more open with that, but I do have a lot of patients who are taking that preoperatively. And I am suggesting we recommend stretching unless they're doing myo. So, they have a stretching protocol that we go through, and there's exercises again, unless they're doing myotherapy. We're not starting stretching for 1 to 2 days. We're seeing soreness within the first 1 to 3 days, depending on the depth. And so
adult is a lot more soreness relative to infants and adults, a lot more, just because they've compensated for so long. All that musculature, all that fascia is there, and so they're going to prime the pump. They're going to be sore. It's really sore. And that's, there's things that can combat it, but go on. Sorry.
And they've got a newfound freedom. So again, that's where miles coming into place. But ice packs on the neck and the back of the neck can be really helpful for your kiddos and adults as well. And then we're seeing they're changing some of it. We've been recommending vitamin E or coconut oil on the wound site afterwards. It's especially with CO2, it helps kind of rehydrate that tissue, but then also is just kind of help with elasticity because you're trying to prevent that reattachment from coming back into place. And so, but there's also kind of more evidence showing that that's not as conducive. I was actually looking at, I can't think of the name for the life of me, but the arnica, the topical, applying that to the wound site as kind of just something to help with inflammation and post-op pain. But yeah, I mean, on average, we're seeing 1 to 3 days of soreness. We're seeing it's about a week for healing typically. And then just following up with stretching or myo for 3 to 4 weeks post-operatively, depending on what that OMT is recommending. We work closely with them and we kind of hand follow-up over to them. So we're not doing a lot of post-op follow-up care aside from just kind of checking in a few days post-operatively, but we work closely and we have a good team. And so we really trust those people we're working with. And so if you're doing this repeatedly, but it could also be another revenue point. So there's a way to code that. And if the dentist, you know, like if you've got that time or place or OMTs in-house, keeping that continued care and a line path. So, and then following up with body care, body work, PT, chiropractic, massage, anything along those lines is super, super helpful post-operatively and pre-operatively. But, and then just cold soothing, like kind of extraction, eating instructions that we're seeing afterwards.
Avoid acidic foods, I mean, we have a whole, I mean, obviously post-op instructions, and you guys probably have, you know, similar to what we have, but yeah, food matters. Tylenol, you know, burning on your kiddo's tongue, not pleasant. But you know,
yeah, definitely not. And then from a cost perspective, what do you guys charge? Let's say there's like no insurances, it's just completely out of network, or you give them the super bill to, you know, talk to their own medical insurance. What are they paying?
around 1,000.
Around 1,000, yeah. And then over here it was like 1,300, and they said it doesn't matter how many frenectomies they need. If they have to do the labial ones and the lingual one, it's just all inclusive.
Yep.
Just do everything while you're there.
Yep.
And you know, I would say all in with consultation time for the doctor and operative time, maybe an hour. So like, let's say it's $1,000, $1,000 an hour. There's next to no post-op. There's next to no overhead outside of the purchase of equipment, which is a one-time capital expenditure based on your cost basis. There's tax and depreciation and different things you have on the unit. And then of course you got some tips and things associated with it. And then a lot of it can be outsourced and streamlined. And a phone call from the doctor at night goes a long way when it comes to a child. But outside of that, it's really not a whole lot of time that goes into it. It's just having the knowledge on all the moving parts and how to, I would say, how to treatment plan it appropriately. How to coach the patients and understand who's ready and who's not. And then how to have the systems in place where you don't skip steps. So just understanding the chronologic sequence of events for the patient based on their presentation. And then when we get into it, not to like marginalize or say it's not a hard procedure to do, but in the big scheme of things, like doing the procedure in itself, I'd say there's very low comorbidities and very low like complications that could occur from it. So like, why are we not doing this? I think we're just not doing this because we don't have the reps and the hands-on knowledge on it. And that's what we're aiming to solve for dentists, is just demystifying that thing that we thought was really scary. That's really not.
Yeah.
And that's what I didn't realize that this was a scary procedure for dentists. It didn't equate to me when we were putting this course together that they're scared of the tongue or the lip. And I'm like, really? Why? You know, 10 years, over 10 years of experience. And I'm like, you just do this and this and this. And even you're like, dude, I don't, you know, I don't. And I'm like, but you're an accomplished surgeon. Like,
it's crazy. I'll place a zygoma, but I was like, where do I cut under the tongue? Where's the muscle roots? Is that the genius glossus? Like, I was like, oh, that's the muscle there. That's the muscle there. It's just, it's wild, right? So I think it's just when you see it, you're like, oh, that's what that is. Yeah, let's do it tomorrow.
Yeah, and like I want to demystify that and make it like I've trained so many residents in this procedure and they're like, oh, that's it. And I'm like, yeah, show one, teach one, do one. I mean, like, let's go, guys. And so yeah, it's one of those things that will make it, you know, 1, 2, 3.
And
Yeah.
the benefits for the patients just are just amazing. So it's really rewarding, especially your kiddos with speech issues, or adults who had speech issues their whole life. Like
Yeah.
that's like the most like heartwarming thing you can really do, is provide that service for them and relieve those social insecurities.
And big picture, all right, airway issues. Let's be part of the solution, not just kicking the can down, you know, the street, the proverbial street, and be part of the problem where we're not looking at this. This is I don't want to say we own this, but this is part of our wheelhouse and we ought to be managing it. And I know that we can. And we just have to give them the skill set and the tools to be able to, and instruments to be able to do that. And that's what I heart, you know, from the bottom of my heart want to do, because it's such a simple, easy thing that you can catch, diagnose, and then treat and get them on their way to, you know, managing head to toe, right? The mouth, the tongue, all of that is part of the body, period. And so let's be able to manage it appropriately. So.
Yeah. And if we talk about procedures, and I'll kind of wrap up on this point, if we talk about procedures where dentists are getting burned out, we get burnt out on the fillings and the crowns and the root canals and the hygiene and the scaling. And to some degree, this is at least my theory, is because you don't get the standing ovation at the end. And yes, we're providing a service and it's absolutely needed. But if you can help someone breathe better, you know, where we're preventing Alzheimer's, we're improving cardiovascular health, we're doing it all with just releasing of the tongue and myo. And of course, there's adjuncts where you can build your sleep program on it as well. You know, I think a lot of us rode the all on X bubble. And to some degree, I think it's going a little bit, the pendulum has swung too far the other direction. So that's why we're creating courses for veneers and crown and bridge and saving teeth courses in CSI as well. But then if we think about also the next wave in dentistry, I believe really the next wave in dentistry for EBITDA, profitability, maximum impact into someone's life, like a generational type of impact, is airway. There's so much research going into what we can do non-surgically. You know, people are going for the Inspire, where they run a cord up to your neck and then your tongue sticks out. You
Sounds
breathe
really
in. Yeah. So it's like, well, why not? Let's start with like some of the layups. Let's do these things. Let's get patients healthier. And at the same time, let's build these programs in our practice where, like, I mean, it's going to be huge. It's going to be absolutely huge.
Yeah.
So, you know, I want to thank you guys for coming on the Zoom call. We're going to get this out to a lot of people who are like just super interested in implementation in the practice. And then I think what really ties this stuff together is the hands-on training you guys are planning and preparing for us. And so I just want to tell you, like, I'm super appreciative that you're taking time out of your busy lives to put this program on to help so many people all over the country, because the ripple effect into their communities and to their patients is going to be it's going to be profound. So thank you so much.
Thank you for putting this on. And
Yeah,
I love CSI. It's our surgical playground. I can't say that enough, because it's truly a place to be able to share, grow, give, you know, repeat, and just thank you.